Today we are going to talk about this paper on cardiac catheterization. The title of the paper Is there a role for endovascular stent implantation in the management of post-operative right ventricular outflow tract obstruction in the era of transcatheter valve implantation? The study comes from multi-center including UK, West Indies, Canada, and USA. The first author is Dr. Kang from Liverpool, UK, and the senior author is Dr. Benson from Sick Kids in Canada. The article starts with the central problem of children with right ventricular outflow tract reconstruction is the need for multiple pulmonary valve replacements. Short and medium term results of TPVR in adolescents and adults are excellent, with recent publications indicating a trend towards earlier pulmonary valve replacement and extended application in younger children and smaller conduit. While these studies report encouraging early results, the limits and long term safety of transcatheter pulmonary valve have yet to be fully defined. Specifically, in the setting of isolated RVOT obstruction, it is important to identify competing risk benefit profiles of those strategies. On to the methods. The authors classified patients into a few groups. The first one is patients with surgically reconstructed RVOT and stent palliation. This is a retrospective study where they collected data from January of 1991 to December of 2017, a fairly long period. And obstructed RVOTs included number one, pulmonary valve replacement with homograft or bioprosthetic conduit, and number two, native RVOT with transannular patch or monocup reconstruction. In general, the indication of an RVOT stent was a right ventricle to systolic blood pressure ratio of more than two-thirds based on echo with or without symptoms such as fatigue or reduced exercise tolerance. Patients who had a transcatheter pulmonary valve replacement within 3 months of stenting or the stents were used as a pre-stent for transcatheter pulmonary valve placement were excluded. Data from a subset of patients from this cohort have been previously published by the authors. The second group of patients were patients with surgically reconstructed RVOT without stent or percutaneous palliation. To characterize the impact of the RVOT stenting on unobstructed conduit or surgically reconstructed RVOT, authors performed limited data collection on a separate cohort of patients with biventricular circulation who underwent surgical RVOT reconstruction during the same study period. The authors then briefly described the technique of stent implantation, where they emphasize the importance of taking aortic root or selective coronary angiogram. And in children with an RV2PA conduit, the maximum balloon diameter was generally 10 to 15% larger than the initial conduit size. The primary outcome measure for this study, this cohort, were subsequent pulmonary valve replacement, whether surgical or percutaneous, and death before pulmonary valve replacement. On to the results. I will focus on the tables first, which gives us a large part of the information. So table 1 shows patient characteristics and data related to initial right ventricular outflow tract reconstruction and primary stent procedure. Here we can see 67% were male, 50% patient had tetralogy of Fallot, 22% had a common arterial trunk, 13% had transposition or malposition complexes, and 9% had left ventricular outflow tract obstruction. The age at initial repair or initial conduit insertion were divided into three groups. Less than 1 consisted 51% or majority, 1 to 5 years were 34%, and 5 to 16 were 16%. Looking at the type of RVOT or conduit, 52% were homographed, that was the majority of the patient. 33% were stentless bioprostheses, 6% were stented bioprosthetics, 3% were native, and 7% were others. The initial conduit diameter were as follows: 10% were less than 10 millimeters, 38% were between 11 to 15 millimeters, 28% were 16 to 19 millimeters, and another 16% were more than 20 millimeters. Age at primary RVOT stent were divided into three groups: less than 1 year, 1 to 5 year, and 5 to 10 year. Majority, which is 31%, were 1 to 5 year, and another 31% between 5 to 10 year. Only 6% were less than 1 year. At the time of cath, the pre-stent angiographic RVOT diameter was a mean of 8 mm and a range of 2.2 to 15.8 mm. The conduit was calcified in 25% of the patients. The type of stent at initial catheterization were as follows: Palmer's 4 series, Palmer's 8 series, Palmer's XL, and Palmer's Genesis, the 10 series that includes Palmer's Genesis 1910, 2910, 3910, and 5910. These Palmer's Genesis 10 series were the largest or the most commonly used and consisted of 24% of the stents used. There was also Andra stent and other stents like CP, Valeo, Atrium, etc. The median age and weight at the initial stent placement was 7.3 years, and the median weight was 21.1 kilo. The median balloon diameter was about 15 millimeters, ranging 8 to 25 millimeter, and the median ratio of balloon diameter to minimal conduit diameter from lateral projection angiogram was 1.8 with a range of 1 to 4.8. On to table 2. The table 2 shows hemodynamic and angiographic variables at primary stent implantation and subsequent catheter interventions, re-interventions. So the primary RVOT stent that happened in 151 patients, the RV pressure before the stenting was 64, after was 43 with significant p-value. PA pressure was similarly increased after the procedure significantly. The RV to PA systolic gradient went from about 40 to 14 with a significant p-value. RV to aorta systolic pressure ratio went from 0.7 to 0.49. Minimum RVOT diameter increased from 8.3 to 12.7 with a significant p-value. In the second catheterization, there were similar increase in PA pressure, RV to PA systolic gradient improvement, reduction of RV pressure, reduction of RV to aortic systolic blood pressure ratio. The majority of the children exhibited a significant decrease in the RV to aortic pressure ratio and or RV to PA gradient after the intervention. From a multivariable cause-specific hazard regression, a higher pre-stent RV to aortic pressure ratio was significantly associated with a conduit gradient of more than 15 mm after intervention. For subsequent percutaneous re-interventions, in 1/3 of the cohort, which is 51 patients, a second cardiac catheterization was required at a median interval of 1.8 years after the initial implant due to recurrent RVOT stenosis. The multivariable Cox regression analysis indicated that the covariates younger age at initial RVOT stent, higher post-stent RV to aortic pressure, and higher RV to PA gradient were significantly associated with the need for subsequent re-intervention following initial RVOT stents. We look at table 3 now. The table 3 shows demographic and hemodynamic parameters of children with and without subsequent catheter reinterventions before subsequent pulmonary valve replacement and multivariate regression analysis of factors associated with primary outcome. So age at initial RVOT reconstruction in the no intervention group was 2.13, the reintervention group was 2.6 with a multivariate hazard ratio of 1.24 with a significant p-value. The other multivariate significance was post-stent RV to aortic ratio, hazard ratio of 1.42 with significant p-value. Post-stent RV to PA gradient was 1.04 with a significant p-value, and post-stent RVOT minimal diameter had a hazard ratio of 0.8 and a p-value of significance. The authors then talk about the complications. The complications were mainly divided as acute and late. The acute complications that required surgical management were one stem embolization, one conduit rupture, one total right pulmonary arterial occlusion. The complications that required percutaneous management were stent malposition requiring additional stent placement, RPA dissection requiring stent implantation, balloon rupture requiring retrieval of embolized fragment, and the ones that needed conservative management, partial balloon rupture and uneventful retrieval, small confined conduit tear, partial right pulmonary artery occlusion, and small pulmonary hemorrhage. Now on to the primary outcomes. 102 children, which is 68%, reached the study outcomes of PVR or pulmonary valve replacement or death before subsequent pulmonary valve replacement. The median interval from RVOT stent insertion to subsequent pulmonary valve replacement was 3.1 years, with a range of 3.6 months to 12.7 years. The estimated freedom from pulmonary valve replacement was 91% at 1 year, 51% at 5 years after RVOT stent implantation. By multivariable cause-specific hazard regression, smaller balloon size for stent deployment within the range of 8 to 18 mm was strongly associated with shorter freedom from pulmonary valve replacement. We'll focus into figure 1, which shows cumulative proportion of patients on the y-axis and years from stent implantation on the x-axis, which shows surgical or transcatheter pulmonary valve in this red line that goes up with time. In the figure B, on y-axis there is cumulative proportion of children with surgical or transcatheter pulmonary valve replacement, and the x-axis is years from stent implantation. You can see younger children had the highest number of pulmonary valve replacement, followed by 2 to 10 year and older than 10 year with less number of pulmonary valve replacement. Next, follow-up of children with RVOT stent who did not reach primary outcome. There were 49 children who have not reached the primary outcomes. In these children, the most recent echocardiogram at median of 5 years after initial RVOT stenting showed good RV function, a median RV to cuff systolic pressure of 50%, and RV to PA peak Doppler gradient of only 46 millimeters. Next, looking at the trends in right heart dimensions after RVOT stenting by echocardiogram and MRI. Before the initial procedure, 83 children, which is 55%, had pre-existing moderate or severe pulmonary regurgitation on echocardiogram with a RV end-diastolic z-score of 2.8. The initial RV end-diastolic z-score after stenting was compared to that at the last echocardiogram before PVR or the most recent follow-up at a median time of 5.9 years, and no statistical difference was found. In this figure, the authors have shown The RV end diastolic dimensions Z-score by echo at pre-stenting and subsequent years with no significant increase. However, when they compared the MRI end diastolic volume in 13 children before and after stent implantation shows an increase at a median interval of 2.1 years from baseline. The RVDV was 113 and even increased to 127. In 7 children, there were no differences in RVDV on consecutive MRIs after stent and before primary endpoint at a median interval of 4.5 years. Coming on to the all children with surgically reconstructed RVOT with or without RVOT stent or percutaneous palliation. The 355 children who underwent surgical RVOT reconstruction during the study period but did not have RVOT stents were also evaluated. The freedom from subsequent pulmonary valve regurgitation from the time of initial surgical RVOT reconstruction was 85% at 5 years, 36% at 10 years, and 53% at 14 years respectively. Children who underwent RVOT stent and further percutaneous reintervention had longer freedom from pulmonary valve replacement compared to those without RVOT stent palliation. We'll go and look at figure 3a, which shows surgical transcatheter pulmonary valve in this axis and years from initial conduit insertion in this axis. And you see it goes up with time. Now looking at the three groups, the red one is no stent, no intervention, going straight for pulmonary valve replacement, has the least years from initial conduit insertion. The second group with prior stent has better than the first group, and the best of the three is the group with prior stent and reintervention in terms of proportion of patients who needed pulmonary valve replacement down the line. Now, coming on to discussions. The authors write an excellent discussion on the use of RVOT stenting in this population. They say that their long-term experience showed that stent placement in an obstructed RVOT results in an effective relief of obstruction and can delay subsequent PVR. In two-thirds of this cohort of 99 children who have undergone further pulmonary valve replacement, stent implantation deferred surgical revision for a median of 3.1 years. In the overall cohort of 151, including children who have not reached primary outcomes, Kaplan-Meier analysis showed that stent palliation extended conduit longevity by 5 years in half of the children, as we saw in figure 1. Serious complications, including stent embolization, conduit rupture, which required surgical intervention, occurred infrequently, and there were no cases of endocarditis or deaths related to the procedure. Authors reviewed other studies which supported this notion. Dr. Peng reported midterm outcomes of a largest series of conduit stenting in 221 children with an excellent hemodynamic result and safety profile, delaying surgical pulmonary valve replacement for a median of 2.7 years. While a high incidence of 43% of stent fractures were reported due to sternal compression, this was not associated with hemodynamic compromise. The stent fracture was encountered less frequently in this study and that of other studies, likely as a result of multiple factors, including different stent types and follow-up investigations. The drawback of this stenting the RVOT, as we all see the elephant in the room, is the PR induced by stent deployment across the valve. However, the authors did not observe a significant increase in echocardiographic RV and diastolic Z-scores before or after stent implantation or at subsequent follow-up before subsequent pulmonary valve replacement. Neither they saw a compromise in RV function. Nevertheless, the detrimental effects of chronic regurgitation and RV volume loading are well described. The extent and duration at which critical or irreversible RV damage occurs, however, is unknown. In the asymptomatic child or adult with RVOT dysfunction and RV dilation, the optimal timing of pulmonary valve regurgitation is a moving target. In older children and adolescents whom transcatheter pulmonary valve replacement and RVOT stent are viable options, transcatheter pulmonary valve is intuitively appealing because it is less invasive than surgery and addresses both stenosis and regurgitation. However, contemporary medium-term outcomes of transcatheter pulmonary valve replacement prompt careful consideration of its risks and benefits in management of RVOT dysfunction. Young age at pulmonary valve replacement has been associated with short time to RVOT dysfunction for multiple reasons, including stenosis related to small initial size of the pulmonary valve, that is the 18 millimeter valve internal diameter, and outgrowth of the conduit, and an increased rate of stent fracture even in the protected cohort. In children with predominant pulmonary regurgitation, transcatheter pulmonary valve did not improve clinical or functional outcomes similar to that of surgical series. The annualized incidence rate of infective endocarditis ranges from 2.4% to 3.6% from large series of transcatheter pulmonary valve replacement, with younger age at implantation less than 12 years and an immediate post-implant P gradient of more than 15 mm are associated with development of infective endocarditis. When the outcomes of pulmonary valve replacements were evaluated according to age at implant, it revealed younger age at implant to be significantly associated with increasing gradients over time. Therefore, it is reasonable to advocate RVOT stenting over pulmonary valve placement in older children in whom discrete conduit stenosis is predominant pathology and the RV is not significantly volume overloaded if the conduit was diffusely stenotic due to somatic outgrowth, particularly when associated with the bifurcation stenosis of branch pulmonary arteries. Surgical pulmonary valve replacement is recommended. The limitation of the study is mainly its retrospective nature and heterogeneity in management strategies over 3 decades. The other limiting factor is the end-diastolic diameters mentioned of the RV was only by echocardiogram, which probably is not as reliable as MRI. The limited comparative MRI studies were available for some patients and it showed similar results. In conclusion, the author's long-term experience supports stent implantation as effective and safe palliation for obstructed RVOT, allowing deferral of surgical or percutaneous pulmonary valve replacement, both its own inherent set of risks. Pulmonary regurgitation following RVOT stenting is an undesirable but unavoidable result, but is clinically well tolerated and did not appear to significantly affect RV size or performance in our cohort. Further, percutaneous interventions on stented conduits were similarly effective in prolonging conduit lifespan. In the lifetime management of RVOT dysfunction, stent placement remains an important tool to treat pathologic pressure loading of the RV, allowing somatic growth and hence optimizing the longevity of subsequent surgical or transcatheter pulmonary valve replacement at an older age.